thank you all for joining our Northeast Ohio Opioid Consortium meeting. We have these quarterly, and our hope is that we can share evidence-based practices and focus on harm reduction, treatment, and prevention of substance use disorders and opioid use. And so just a little bit of history. The Center for Health Affairs formed the Opioid Consortium with our hospital partners in 2017. And that is when all the hospitals came together with the Cuyahoga County Opiate Task Force and the United States Attorney General Attorney's Office for the North District of Ohio. We were trying to implement a hospital-specific response to the opioid crisis. Over the years, we have provided education. We have worked with our community partners, and we've promoted policy change and increased prevention efforts. Today, I would like to turn it over to Dr. Joan Papp, who is a member of the Opioid Consortium Advisory Council, and she was instrumental in inviting our guest speaker today, and we look forward to the presentation.
Thanks so much, Jody. And I am really thrilled to see just how many people registered and joined us today for this really important topic. About 6 months ago, our opioid safety team at Metro was lucky enough to meet with Dr. Jean Hearn and learn about the California Bridge program and the EMS Bridge program. And while we had originally intended to have Dr. Hearn as our guest speaker, we had a slight change in the schedule today. We learned, unfortunately, earlier this week that Dr. Hearn was hospitalized and is unable to join us. However, he was kind enough to coordinate with Vanessa Lara, the program director of the EMS Bridge program. Vanessa Vanessa was essential in launching and maintaining the EMS Bridge program. She administers the $1.5 million grant, which led to expansion of 8 additional counties in California. And she also leads research on the novel approach to paramedic-initiated medication-assisted treatment. Her team's research has led to policy changes in California, and she has over 10 years of experience in the healthcare field and holds a Master of Science with focus in analytics. So without further ado, we'll go ahead and pass it off to Vanessa to tell us about the EMS Bridge program.
Thank you. Thank you. I'm so excited to be here and happy to step in and help out. Thank you for that lovely introduction. Again, my name is Vanessa Lara, and I'm the project director for EMS Bridge. I've been working with Dr. Hearn for the past like almost 5 years now. Time flies. And together we have developed and designed the EMS Bridge program. So you're going to hear me mostly talk about the EMS Bridge, but I will talk about the California Bridge program as well, so you can kind of see where all of these different programs fit in the larger scale. Okay, so let's get started. Slide, please. Okay, so I want you all to imagine this wherever you live. 911 has just been called to respond to a possible overdose. And when EMS arrives, they learn that the patient is a 24-year-old person who was recently released from incarceration, and they're found unconscious at a friend's house. It's a very common scenario. When EMS arrives, they give the person, they were given 2 milligrams of intranasal naloxone, and the patient becomes alert. And after they receive the naloxone, they report to the paramedic that they're feeling some uncomfortableness and some possible signs of opioid. And the patient's pain is so severe that he doesn't feel like he has the ability to sit still through an assessment. He's anxious. And instead of being transported to the hospital, the patient is just requesting to leave. And in this moment, think about the EMS in your area, what can EMS offer this patient? If they don't want to be transported and they don't want anything else, how can we make this patient more comfortable? Let me just think about it for a couple seconds. Slide, please. I think one more.
Jody, one more slide, please.
Okay, so now that you've thought about it for a second, the reality is that in most places, EMS does not have the tools to give anything to this patient that would alleviate their opioid withdrawal. That's typically done at a hospital. So the patient could possibly be provided with some supportive medication like Zofran or fluids. They might be transported to the emergency department, or the patient will self-discharge. And we thought that that just wasn't enough. Slide. We proposed a new standard of care for encounters involving overdose and substance use disorder in the field. So we learned that in addition to assessment, treatment, and transport, that paramedics can screen for substance use disorder. They can practice motivational interviewing to discuss substance use disorder treatment, and paramedics can safely administer buprenorphine and provide naloxone to their communities. And then their efforts can be continued at a hospital who connect the patient to resources and guide them along their journey through the medical system, which is a monster. Slide, please. And this is a figure from the CDC, just kind of telling us that, these overdose deaths are going to continue to rise. A lot of people often ask us, why should EMS be involved in medication for addiction treatment care for patients experiencing substance use? After all, they aren't addiction specialists, they aren't doctors, and they aren't operating out of an outpatient clinic where most of these treatments typically take place. But EMS is in an incredibly unique position as mobile caregivers, meeting the patient literally where they are at. As I'm sure you're all aware, many of these vulnerable populations often use EMS as their primary main source of primary care. And they never make it into the hospital. So without this, we're not catching some of these patients, which is really important to note. And they have the chance, EMS has the chance to provide the safety net to this vulnerable population. And again, this graph I'm sure is not news to anyone, but we should feel increasingly devastated every year that we see it rise without implementing further interventions. And this year alone, I know the CDC mentioned about 102,000 deaths, which I think we've kind of seen a plateau. Some recent data, preliminary data has come out, and we are starting to see some overdose deaths plateau, but this number is still incredibly huge, and that just further ensures that we should not let our foot off the gas pedal, and we should keep it there. Slide, please. Oh, yes, and then here's the numbers. And this is a graph we often like to share as well. It's really interesting to see that as the opioid prescribing decreased, overdose deaths increased. Now, this data is from 2020, but I think it still holds true that many of the patients who were previously prescribed opioids and then had restricted access or limited or restricted or no access to to their typical opioid prescription, typically turned to straight opioids, which is just increasingly dangerous. Slide, please. Now, this is some data from the California Bridge. The California Bridge is kind of our parent slash sister program. We're part of the entire Bridge program, and we have several programs under that umbrella. Specifically, of course, we're the EMS Bridge, but the California Bridge started this work in the emergency departments. We noticed that there was a huge need for resources at the hospital. There was a lack of clinical knowledge and a lack of evidence-based treatment in the hospitals. So what the California Bridge did was develop resources, evidence-based resources and trainings to give to clinicians in the hospital and how to treat opioid use disorder in the hospital rapidly and continue prescribing for patients. They also implemented a navigator. So about the California Bridge started in about 2018 in just a couple of hospitals in California, around the Bay Area and Southern California. And then that just exploded to 287 hospitals out of the 300 in California, which is such rapid growth for this period of time. Really believe in just quick solutions, not quick solutions, but fast, they were able to act quickly. And this also created a lot of jobs. So a navigator or a substance use navigator was positioned at the emergency departments to consult with the patients who were coming in with potential overdoses or potential substance use disorder and get them connected to treatment. So you can see some of the numbers here. To date, this number continues to rise every day, but these are some of the numbers, patients seen for substance use disorder, a lot of patients who were identified, and a lot of prescriptions for medication for addiction treatment, which we're really excited. And we're also excited to report that over close to 200,000 naloxone kits, harm reduction tools, were also distributed to patients. Slide, please. More statistics. And again, that number increased. This is 276 hospitals, but yes, we're at 87 hospitals now in California. And we're excited to report that most of those hospitals sustained their navigator or made it a permanent role within this, within their hospital. And it's a myth. We've found that it's a myth that patients do not want treatment. A lot of times the issue was that they just weren't offered the treatment. There was no connection to those resources. And navigators in the hospital, as well as knowledgeable clinicians, have made medication for addiction treatment a lot more accessible. So we're connecting patients and keeping them safe. Slide, please. All right, now back to EMS Bridge. We are also following a similar trajectory. And again, this is the reason that we implemented this program. We saw an opportunity that it wasn't enough to just stop at the hospitals. We wanted to extend this program into EMS. And one of the reasons is that survivors of overdose death have a high risk of death. And this study published by Annals of Emergency Medicine looked at over 11,000 patients that were treated for an opioid overdose, and over 5% of them died within the year. That's an alarming statistic. 29 of them died within the first 48 hours, and the study just really shows the vulnerability of overdose patients and how critical it becomes to provide the necessary medical care to them. And I added a QR code if you all want to take a second to scan it, and you'll have the opportunity to read that resource fully. And here's another study where 1,600 overdose encounters involving naloxone administration were reviewed, and 42% of them refused transport. So was a population who often does refuse transport because once they've been reversed, they know that EMS doesn't have anything further to provide them, and being transported to a hospital potentially far away from where this patient stays is just an inconvenience to try and get back to wherever they're staying. And then the transport denial resulted in a 66% higher risk of overdose. So extremely high risk population. Slide, please. Now, we work closely with the San Francisco Fire Department, and this was a review that they did. They conducted a cross review of patient care reports that EMS writes, or that EMS submits, and coroner reports. And they found that the San Francisco Fire Department had contact with 50% of the people who suffered a fatal overdose in the year prior to their death. So, um, they saw that as an opportunity that the patient had been touched by EMS 1 year prior to their death. And that just encouraged them to act and implement some of these resources in San Francisco. So more reason to support EMS implementation. Slide, please. So we started this program back in 2020 as just a small pilot here in Contra Costa County. We partnered with the 911 system here, which is AMR or GMR. And we modeled it after Camden, New Jersey. To our knowledge, Camden, New Jersey, Cooper University was the first to implement MAT initiated by paramedics, and we modeled it after their wonderful program. But we actually were able to expand the scope of the paramedics beyond Camden's scope. And patients were able to be treated either post overdose, or if patients were just calling 911 because of their severe withdrawal. And we built our program to center around these 4 pillars of care, which we'll go over. Slide, please. The first pillar of care was the naloxone distribution program. Every paramedic and EMS unit was actually equipped with several boxes of naloxone. So anytime a patient would call for an overdose, or just patients who seemed more at risk, EMS would start handing these boxes of naloxone out. And they would distribute it to everybody in their community, anybody who asked for one free of charge. They were just passing them out, which is fantastic. And there's been over 400 boxes since 2020 left with patients. And it's really difficult to track this number. So we kind of just hear back from the patients if they received a box of naloxone, but we know of 20 overdose reversals that have been treated with the naloxone that EMS handed out to them. So that's really great to hear. But again, it's very difficult to track this number. Next slide, please. The second pillar of care was our overdose receiving center. So similar to a stroke or a trauma center, we wanted to highlight the hospitals that were connected with the California Bridge program, that had a navigator in their hospital, clinicians that were knowledgeable in evidence-based treatment, because we believe that those hospitals gave the patient the best chance at being retained in treatment long term. And we proposed a couple of standards. I won't go through all of them, but just as a quality assurance, where the emergency room follows some sort of standard for opioid use disorder, And now the X waiver is no longer needed, but at the time it was a place where the ER staff, there was always an X waivered clinician available. And yeah, a lot of connection to outpatient treatment. Slide, please. Thank you. And these are some of the numbers. So we believed our system worked because the retention rates here in Contra Costa County at 7 and 30 days were recorded. So you'll see on the far left, patients that went to a bridge hospital were actually much more likely to be retained in long-term treatment. And we believe it's because of the qualifications of that bridge hospital. And we'll use overdose receiving center and bridge hospital interchangeably, but essentially just a hospital where the California Bridge has made its mark. And these numbers are just incredible to see. 30 to 35% of patients were retained in care at 30 days, meaning they went to an outpatient appointment, or they went and picked up their prescription. So all good signs that the patient was continuing long term. Slide, please. And then these numbers are a little bit higher now with more recent data, where we saw 39% of the patients continued in MAT care at 7 days and 29% at 30 days. So incredible retention rates. Slide. Our third pillar of care was a warm handoff to public health. We connected the counties to their public health department. And in Contra Costa, it's a very unique situation where the public health department, EMS, and all of the hospitals in this county actually talk to each other. They have an open system where where public health can actually review EMS's records without it being a long, drawn-out process and a lot of barriers regarding patient health information. So EMS patients with a potential substance use disorder were flagged in EMS's system. EMS went to an overdose. The EMS would flag those patients, and then those patients would be referred to the navigator to provide a follow-up. So whether they were transported to a hospital or not, the navigator would always reach out to them just using their contact information that EMS gathered, and they were able to connect them to treatment and resources. Slide, please. And of course, the last pillar of care is EMS initiated buprenorphine. So we trained all of the paramedics in Contra Costa County on the history of opioids in the US, pharmacology of buprenorphine, motivational interviewing to help them talk to patients with open-ended questions to help essentially motivate them to discuss further treatment and just get them open to the idea of potential treatment. And then buprenorphine in the field. And all of our trainings, they're free and accessible online. We used to do a 4-hour training, and we've condensed it down to 1 hour for paramedics. And we found that this 1-hour training does the trick. Paramedics are knowledgeable, and they're treating patients out in the field successfully. And again, I've attached a QR code here if you would like to review the training. I believe this takes you to our YouTube page, but again, it's open access and very easy to watch, easy to digest under an hour. Slide, please. And here's some more data about the patients in Contra Costa County from our first couple of years. We noted that this was safe and effective. 77% of the of the patients that received buprenorphine in the field reported a decrease in withdrawal symptoms. So they were finally feeling some relief just after calling EMS. 22% noted no change. There were no reported cases of precipitated withdrawal. And for those who are unfamiliar, precipitated withdrawal is when you are not exactly in withdrawal from opioids yet. And when you receive that medication, like buprenorphine, it just throws you into withdrawal. So we're happy to report that, the paramedics were knowledgeable and were able to treat correctly every single time. And there were some patients who were admitted to the hospital after being transported. And again, happy to report that none of them were related to receiving buprenorphine in the field. These are some of the reasons that the patients were admitted following their buprenorphine treatment. Slide, please. This is a bit small, but this is our algorithm that the paramedics follow. It's very simple. They carry this on the rigs at all times to just in case they need it for reference, but it's pretty straightforward. The paramedic will assess the objective signs and symptoms, and then they'll assess for any exclusion criteria. We paramedics are able to provide this medication up to 16 years of age and older. So they're also treating pediatric patients. And that's been a recent change. We noticed that there's a lot of pediatric patients who are in need of buprenorphine treatment in the field, which is scary to think about, but it is a reality. So we made that change earlier this year. And so far it's been working well, and they follow the same recommendation as the adult patients. And if the patient or the paramedic will move down the line here, they check for a clinical opioid withdrawal score, and our level for that is about 8 points. So they can use this MD calculator. They have the QR code as well, so they can calculate that clinical opioid withdrawal score pretty quick. And then they offer the patient buprenorphine. They'll do some motivational interviewing with them, see if they've tried bup in the past. And if they are amenable to buprenorphine treatment, the patient is given 16 milligrams of sublingual buprenorphine. And they're able to redose with 8 more, so for a total of 24 milligrams of buprenorphine in the field. And we find that the 16 milligrams works flawlessly. And then further down this algorithm, the patients are either transported to an emergency department, and hopefully that's where they're able to meet with the navigator. And again, because of our system, the navigator is alerted as soon as the paramedics start treating this patient, so they're prepared to receive that patient. And if they never make it to the hospital, the navigator at the hospital will actually reach out to the patient. So we have a system down here where we can make sure that the patient has all of the resources that they need. And again, QR code here if you'd like a link to save this. And I wanted to share this patient experience. This is just one of many. It is often a little bit difficult to receive patient feedback, but this is just one of the great patient feedbacks that we've received. And I'm going to read it out loud just for impact here. This patient said, "I was very sick in precipitated withdrawal. They were able to offer me the Suboxone medication. I was able to take the medication right on the spot. That 30 minutes was vital in getting back to normal. Even though it was only 30 minutes, that helped me a lot. We were able to go to the hospital where I received care, and I got more Suboxone. It made the biggest difference in how I felt and was able to come to and realize what was going on." Slide, please. It ultimately led me to the road of recovery. I'm in recovery and have that medication, and having that medication restarted my life. because of that medication, I'm able to do things now with my life that wouldn't have been possible without that medication. So I think it's great that you guys are able to offer it right on the spot. I've never seen that before, and for me, it was vital for my recovery. I've been able to function on an everyday basis and live a normal life. Now I'm a student at UCLA and going to be going to school. So that's just one of the ways that it's helped me. I've been waking up feeling grateful and proud, and it all started with taking that medication. I just want this program to be able to be offered to everybody, and I know how helpful it was for me. So if it could be extended out to the surrounding counties, that would be amazing. I can see the difference it could really make if people choose to take it in that direction. So we were so excited to get this feedback from this particular patient, and we don't label every successful patient, as starting at UCLA. Of course, that's wonderful, but we really believe that success is just even starting to talk to the patient about treatment. We know that there's some very critical periods of people who are struggling with substance use disorder, and anytime that they're able to access treatment, just talk about it, hear about it, it's it's an opportunity to provide them with this. So although some patients may not choose to continue in long-term treatment, we think that providing them with buprenorphine, at least in that moment, is a lot better than no Suboxone at all. It definitely lessens their risk for subsequent overdoses. So we're really excited to report that. Slide, please. And this is just some of the impact that we've made since then. Our full impact report is also, I love QR codes clearly, is also linked there. But I just wanted to talk about the rapid growth that EMS Bridge has had. And again, by following the trajectory of the California Bridge from going, from a handful, 5, 10 hospitals to 287 today, we're doing something very similar with the EMS Bridge. We started out just in Contra Costa County in 2020, and by the end of the first year, there were 3 new counties joining: Alameda County, San Francisco County, and a couple more in Southern California. And now we're engaged with 19 counties in the state. 13 of those have active BUP. And then the other counties that are not active are engaged with us. They're either starting their training with the paramedics, or they're just implementing the initial phases. And that's just incredible growth that we did not expect. And yeah, here in California, we have reached a third of the local EMS agencies. And we just completed a DHCS award, a Department of Healthcare Services award, for five local EMS agencies covering 9 counties. So we're excited to dive into the research, dive into the data, report on the outcomes, because we're really seeing some positive outcomes from this program. Moving forward, we have actually begun to talk about piloting new models for EMS Bridge. So going beyond substance use disorder, we think that the navigators can actually capture a lot more patients, looking at other comorbidities, and just being able to have the resources to connect patients to housing, food insecurity, domestic violence. So we're expanding and we're growing, and it's a lot of exciting work here in the field. And I think that brings us to the end of our presentation. And if you're interested, again, QR code, please scan the QR code, visit our resources here. And I'm happy to take any questions.
Thank you so much, Vanessa. This was a great presentation. I'm thrilled that we have so many EMS leaders on this call, And I'm wondering, if you have any advice to the EMS directors. How would you get something like this off the ground? What initial steps would you take? And I would certainly welcome any of our EMS folks to also chime in and ask any questions you have.
Yes, the first step is just being knowledgeable that this is possible. A lot of times when we go into meetings with the EMS leadership, it just seems like a huge lift, and it is. I won't lie, it's a huge lift. There's a lot of people involved and a lot of people from different organizations. So you need to get the hospital involved, public health, EMS, but just looking at other programs that have taken off, it's you're able to do it, and it really does start with EMS kind of getting the ball rolling. Something really interesting that happened in San Francisco was that the paramedics have been administering buprenorphine in the field, and San Francisco has a really, really high rate of overdose and overdose deaths. So the paramedics were so excited to get this into their hands, and start administering it. And within the first 6 months, they had over 100 administrations. And just to compare, in Contra Costa County, we didn't reach 100 administrations until probably the second year of the program. So it was a little bit slow. And there's going to be some hiccups along the way, protocol adherence, the paramedics may not remember, but it's, again, continuing that training. But what we saw in San Francisco was because the paramedics were administering so often, they became experts in substance use disorder treatment administration, that the on-call physicians at San Francisco General called the paramedics to learn more about it because they had a patient in their emergency department that needed Suboxone. So it was interesting to see this kind of turn, that the paramedics were just slightly more knowledgeable on this and were able to provide to walk the physician through the administration. So we loved seeing that.
So Vanessa, there is one question in chat. What does the follow-up look like? Is it by phone or in person? Do you face challenges with populations who don't have phones?
Yes, the follow-up is difficult to do, especially if a patient um, does not have a phone or a way to contact them. Sometimes the paramedics do the best they can to get at least two phone numbers, and then that the patient care report and the patient's information is actually provided to the navigator. And just in Contra Costa County, every county is different, but in Contra Costa, because the navigator falls under public health, they're able to view that information. I know there's some concerns, and just more barriers, more red tape up for HIPAA, and that's totally appropriate. So the navigator will either meet the patient at the emergency department, or they'll follow up by phone, and they continuously scan the system to see if any patients who were potential repeat patients. But yes, I will admit the follow-up can be a bit challenging, and we try to connect EMS to the hospitals and just um, strengthen their relationship. A lot of times, after the patient is dropped off to the emergency room, they seldom hear any outcomes. But we've done a good job of strengthening their relationship, so they're in constant communication.
Vanessa, my recollection from my conversation with Dr. Hearn was that there was also some communication between EMS directly to the Sun navigators that are based in the hospital, and the Sun navigators would sort of take the ball and run with it, and that would be where the follow-up was taking place, and then taking it off of the plate of EMS. Am I stating that correctly?
Yes. So the EMS system, the navigators are able to join that system, which basically is kind of like a call log. And that system will mine the patient care reports that the paramedics fill out for any keywords such as overdose, naloxone administration, um, heroin, opioids, drugs, anything, any keywords like that that the system will mine for on those patient care reports, it flags that patient, and the substance use navigator receives a real-time alert that there's a potential patient, incoming patient, and just kind of prepare for that patient. So all of the navigators in that county will receive that alert, and then wherever the patient is transported to, if they do get transported, the navigator will make sure to catch them in the emergency department.
So we have another question too, and this was something I was thinking about. So Madeline, thank you for raising it. The question is, how is this work funded? So that's my question was, who was sort of the initial funder of the pilot program? And then how have you been able to maintain and sustain the program?
Yeah, it's a good question because this does cost money. It's a reality. We were initially funded by the California Department of Public Health, and that gave us seed funding to start in Contra Costa County. We were also given some more seed money from the CareStar Foundation, which used to be CalStar, um, the um, the air transport. I'm not sure if that operated in other states as well, but it became the CareStar Foundation, and now the CareStar Foundation funds a lot of innovative pilots or programs like this one. And with the CareStar money, we're able to do more research. But the more recent money that we've received is from the Department of Healthcare Services. So they issued a $1.5 million grant to us. And with the 1.5 million, we issued it to 9 counties here in California. So and we just actually submitted our proposal because that funding ended. So we submitted a new proposal to DHCS in hopes that they'll fund another 3 years. And we're really optimistic about it because just with our limited data, we've been able to show very positive outcomes, and this is just something that needs to be adopted.
Right.
A lot of grant writing.
I would like to open it up to our attendees. If you have your questions, please use your microphone, go off mute. You can ask questions or you can put them in the chat.
Yes, please ask more
Follow-up
questions.
questions?
One other piece I'd like to share that I don't think was really highlighted in my presentation was that with the limited research that we've done, this has actually led to policy change in California, which is huge. It doesn't happen often, and it's very hard to. But we got the Emergency Medical Services Authority of California to really listen and understand the impact of this policy change. So when it was just a pilot, the EMS agency actually had to apply as a trial study for paramedics to administer this medication. And at the time, it was even difficult for some doctors to administer the medication because there was the X waiver requirement, more training, and it was just a long training to go through, 8 hours of training just for an MD to be certified with an X waiver to prescribe buprenorphine. So with the trial study, it was also a bit more of an arduous process for the EMS agencies. And just after 1 year, we were able to show that the positive impact that this had, that EMSA, or the EMS Authority of California, actually expanded the scope. So it was a local optional scope of practice for the paramedics. So all it takes is just what we call a LOSOP application, and that EMS agency or that county can begin administering buprenorphine. And this is just limited to paramedics. EMTs do not have the scope, but we do provide EMTs with this training as well. And because of this training, we've seen some EMTs actually elevate some calls to ALS so paramedics can come. So we're also teaching them to correctly identify patients in opioid withdrawal and having them connected to treatment in the field. So the policy change took about a year, and just recently, again, we expanded the scope to include pregnant patients and also pediatric patients, 16 years and older. It's incredible policy change.
Dr. Pap, did you have another question? I see another one in chat.
No, I was just going to comment that will be a barrier in Ohio. Buprenorphine is not on our paramedics scope of practice currently, but that would be an important first step. Sounds like.
Yep. The other question we have is, after the first dose is administered in the field, when does the patient receive the next dose? Would the ED continue administering and send the patient home with the script?
Oh, fantastic question. So initially, the patient is given 16 milligrams of buprenorphine. Traditionally, patients are typically given 8 milligrams in the hospital. Now, Highland Hospital in Oakland has been doing a lot of studies with high-dose buprenorphine, so 16 milligrams or higher. And because there's a limited time that paramedics spend with a patient, we start them off with that high dose of 16 milligrams. It takes, anywhere between 15 and 30 minutes to reach maximum effect. And then if the patient is still not feeling well, they'll re-administer with 8 more milligrams. And then once they reach the hospital, that's the goal, is to, once they reach the hospital, they're a lot more comfortable. So they don't spend as much time in the ED. They've already been treated. The emergency department clinician can see them and then just follow that recommendation, which is typically they'll give them a script for 7 or 2 weeks, and then refer them to an outpatient clinic, and the navigator is there along the way to kind of guide them through that. Yeah.
Great. Okay, last chance for everyone to ask your questions. Not last chance, because we'll continue the dialogue with Vanessa going forward, but would love to hear from folks. Well, thank you so much, Vanessa. We appreciate you sharing this. I think there's a lot of tidbits and opportunities to replicate and scale this work as we continue to think about innovative opportunities in Ohio.
Yeah, absolutely. Please reach out. I'll put my information in the chat. Use this as a case study to make your case for this in Ohio, and I'm excited to see where you all take it. Thank you.
And you're welcome to stay on. We're going to do a local spotlight next with our Thrive for Change team. And I'm pulling up your deck.
Do you mind, Jody, if I try to share mine?
Oh, you can try?
Side?
Sure.
Okay, I'll try. Sure. Let's give it a go.
I stopped sharing. Yep. Awesome. While they are pulling up their slide deck, I will copy and paste. We do have an evaluation. We are supported by the OD2A local grant, working with the CDC and the Cuyahoga County Board of Health. And for evaluation purposes, we have a survey that they would like us to fill out following the training. So that is in the chat box. If you're able to receive that, we would appreciate you filling that out. And Vanessa, thank you for sharing your information. I was going to get that out to folks, and we'll be sure to share the slide deck as well.
Okay, let me know.
Awesome.
It says that I'm sharing, but
yep,
I'm not.
We can see
it. Okay, all right,
yep.
Great. All right, 1 second. Well, good afternoon, everyone. My name is Bethany, and I have my co-presenter, Ashley, on. We'll get to full introductions here in a second. We are with Thrive for Change. We're a local harm reduction focused nonprofit based out of Cleveland. And our mission is to promote the health, hope, and healing of individuals at risk of overdose and their loved ones through collaboration, advocacy, and direct service. We're a state designated Project Dawn program, and we're excited to share more about who we are and also highlight a project we're doing in collaboration with EMS locally. So again, my name is Bethany. I'm the Executive Director of Thrive for Change. And I'm going to pass things over to Ashley to introduce herself and then go through some of our programs briefly, and then we'll get into this specific project.
Hi, everyone. My name is Ashley Rosser. I just wanted to take a second and say I actually cannot see the slides. Maybe it's my internet, but I can follow along from the slides I have on my screen. But yeah, my name is Ashley, and I'm the harm reduction educator at Thrive for Change. I have lived experience with drug use. I spent most of my life using drugs, and I dedicated my life to doing harm reduction work after losing my ex-boyfriend to a preventable overdose. So yeah, I'm going to go into a little bit about what we do. So Bethany, you can go ahead and change the slide. So at Thrive for Change, we do a few different things. So I'm going to break them all down. We do training and education. We do trainings on naloxone, how to use it, assessing the situation, like how do people tell if someone's overdosing or not. We offer this virtually on a quarterly basis. And then we offer this in person as well. Through our website, people can sign up to take a harm reduction 101 course, or they can have it customized to suit their needs, whatever it might be. So if there's a organization or a business, whatever it might be, they can actually sign up to get a training customized specifically for them. This allows us to actually meet the needs of their group specifically. So just across all different types of fields. So whether people work in the food industry, the health industry, other nonprofit organizations, everyone can get this training. And go ahead to the next slide, Bethany. And something else that we do is street outreach. We pop up on sidewalks, parking lots. We partner with other organizations to use their outdoor space. We throw up our canopy, our table, set up our supplies, and we actually distribute in different communities this way. We hand out Narcan and do quick Narcan trainings, and people can walk up to us. We explain to them what we have, and we literally give them everything on the spot. We set up these pop-ups in hotspot communities. So we get data from like the Board of Health locally and the state, so Ohio Department of Health. That data tells us where we should be setting up. So what communities are seeing higher rates of overdoses, fatal overdoses, and where are there gaps in other resources. So that's what we do. We set up in hotspot zip codes. We distribute these supplies. And as well as supplies, we also offer linkages to care as well. And what that means is depending on what people specifically need. So if they need something more than just Narcan, they can actually tell us what it is they need. We got a linkages to care person that's just dedicated to doing that, and they can be referred out to one of our many partner organizations. And we also have a syringe exchange program as well. So in addition to the pop-ups that we do in the community, every Thursdays we have open hours where people can come in and get all these supplies, including syringes as well. And go ahead, Bethany, to the next slide. And if people cannot make it in person to our pop-ups, or they don't live in the area, we also offer a mail order version. So people can go to our website and request all of these supplies through the mail, and we send it directly to their homes. And this is for anyone in Ohio as well. It's completely free of charge. People can get up to 5 kits, along with testing strips and safer use supplies. But if people want more than that, we also allow people to become Narcan distributors themselves. We give them all the training that they need and provide the supplies as well. This allows us to equip people in their own communities to become distributors and, do the work that we're doing. We have we can expand our reach this way instead of trying to cover the entirety of the state by ourselves. And go ahead to the next slide, Bethany. And something new that we started doing is called Alternative Avenues. It's a support meeting for people who don't fit the traditional model of recovery. So if people want something other than abstinence-centered support, they can come to the Alternative Avenue support meeting. This is where people can come who are on MAT, medication-assisted treatment. They can actually come if they want to use the abstinence pathway, moderation management, for example, and people who use drugs generally that may not even want to be in quote unquote recovery or have a goal set yet, but they do want the support and maybe they do want to learn or just build community. We do this every Wednesdays at 5:30. We have 2 locations for this. We alternate between Cleveland Heights and the west side of Cleveland. We always feed people and we always offer our Narcan and safer use supplies, and people can get linkages to care as well here. And go ahead to the next slide. And this is our 2024 impact just this far this year. We have a very small team of just 6. And of course, we have amazing volunteers that help us out. These are some pretty amazing numbers for just having 6 of us on the team. As more and more people find out about our program, there's more people that are wanting to get involved and help. So if you would like to volunteer, contribute, donate in some way, you can switch to the next slide, Bethany. These are some ways that you can do that. We're always open to having people come and jump into our pop-up outreaches and helping us distribute Narcan, do Narcan trainings with community members, or if you want to cook a meal for our outreach, because when we do outreaches, we feed people snacks, and there's a specific outreach that we do once a month where we visit all of the tent encampments that are in Cleveland, and we feed people. So if you do want to get involved, there are many opportunities to join us, and we have all of this information on our website as well. So if you wanted to volunteer, you can sign up there. And now I'm going to transition this over to Bethany to talk a little bit more about our other aspects of the program.
Thank you, Ashley. And I also wanted to highlight just a couple of key things that I think make our program unique. So most of our staff have direct lived experience, and I think that's a key piece of the success and impact of our work. It's something that we incorporate and is a priority in everything that we do and who we bring on our team. And this allows us to really develop trusting relationships with folks that we serve. We see a lot of people who fall through the cracks in other systems and healthcare and social service systems, but through engaging with them on a regular basis on that peer-to-peer model, we're able to develop those relationships and create connections to ongoing care. Sometimes it takes a lot of time. I appreciated the impact story that the previous presenter shared and made me think about a recent story that we have. We had a participant that we have worked with who's staying in one of the local encampments, had been shifted around to multiple encampments over the last over 6 months. During that time, he overdosed over 15 times and was brought back with naloxone from our program, and continued to come back and see us every single week for supplies. He participated as a volunteer in our kit building parties, and through that relationship development and ongoing conversations, when he was interested in treatment, because we never put that on anybody, it's always based on what's driven by them and their priorities. But he called us. We were his first call when he was interested in that, and we got him into treatment that day. and he's been in recovery housing for the last few weeks. So those stories are really what stick with us. But every positive change that we see our participants make is what keeps us going and makes this all really worth it work to see that impact. So thank you, Ashley. I'm going to talk a little bit about our EMS naloxone Leave Behind project. I will say that our project lead, Alicia Starkey, is off today. I'll have her contact information though, and you'll see some photos of her throughout these slides. She's done an incredible job of getting this project off the ground and will be the point of contact for this particular project going forward. But you're stuck with me today for the presentation. So what is a naloxone leave behind? So this is what was referenced as a component of the previous project and presentation, is when first responders provide naloxone kits and resources to individuals who've overdosed or people that is just indicated maybe facing some substance use challenges and their close contacts. These programs are shown to be beneficial. I'll highlight some evidence behind that in a second. But what we are looking to do in Cuyahoga County is through the Cuyahoga County Board of Health's Overdose Data to Action Grant. We know that Metro's Project On has had a program doing Leave Behind with City of Cleveland EMS for several years. So we're also coordinating with them on this, but we noticed that there was maybe some other municipalities throughout the county that could benefit from this project. So we put it in our scope of work for this next round of OD2A, because we know that folks that have recently survived an overdose and interact with EMS are some of our most at risk, as has been shared previously today. So our goal for this project is to implement this initiative with 2 to 3 districts or departments. This can be with police or EMS or both. The kits that we've constructed include naloxone, fentanyl testing strips, information on local resources, and a QR code with links to overdose response training and additional resources. Through partnering with the departments, we never want data to be a barrier. However, when possible, our goal is to track the number of kits distributed and who they're going to, whether it was the individual or the family, and any demographic information that is available. Now, these approaches and these naloxone leave behind projects have been shown to be successful as an approach, as they make naloxone more easily accessible for those who are most likely to encounter or experience an opioid overdose. And studies show these programs can increase likelihood of engagement and peer support and other services, expand access, obviously, and then reduce overdose fatalities. So included also in the resource list is like how people can connect with our linkages to care person, and also like local hotlines and things like that. And we're able to track when different links have been clicked on, how many people are scanning the QR code, etc. So here's some highlights of what we've been able to do to date. So we explored partnerships with several different departments, looking at like high need areas. However, Mayfield Heights Fire was the first department that was like really engaging on this. So we moved forward with them initially, and we're still very much seeking other departments that may want to engage. And again, this could be a great introduction and piece of kind of that larger project and example that we were already shown today. This could be a small step in that direction for some departments in accessing these resources to give people on the ground. So we just launched with Mayfield Heights in May. We trained 19 first responders on harm reduction, on layers of stigma, person first language, post-overdose aftercare from a perspective from someone with lived experience, and an overview of the project. We dropped off 100 kits for them to start distribution, and it's still a little too preliminary to have direct impact numbers on that distribution, but hopefully we'll have more to share in the coming months. I also just wanted to highlight, if anybody is interested in implementing one of these projects with your department, Alicia's information is on the screen, and we can include it with the information that Jody sends out. And we're really excited to move this forward with other departments. And I also wanted to highlight the data piece. So it's been cool to see Mayfield Heights actually integrated the data collection that we would like to collect into their existing system. So they've added like a checkbox if a leave behind kit has been distributed, and so that they can send those reports back to us every single month. And it's easy for their responders and staff to just select that as a part of the normal process, which is what we wanted to make as simple as possible for folks. So again, if you'd like to get involved, please reach out to us. And here's all of our emails, and I'd love to see what questions folks may have.
Thank you, Bethany. That was really important to see the great work happening right in our community. So I love today's presentations really flow nicely with a large county pilot from California, and then we focus on what we're doing locally. And I liked your comment as well about this as a great lead-in to a larger pilot that was demonstrated before. Are there any questions? I see one question. Is there a cost for your naloxone trainings? Do you provide virtual trainings?
Ashley, do you want to take that?
Yes, so thank you. We do offer virtual trainings. We post a quarterly harm reduction 101 with naloxone training. So once every 3 months, that's public, it's posted, it's free. But then we also offer the customizable courses as well. So for anyone, whether you're an individual or you want to get training for your team, you can visit our website and fill out the form. And it tells us everything we would need to know about what your needs are. So there's different topics that you can choose from, letting us know how many people are on your team or in your group that you would like us to prepare for. And then, yeah, the best next steps. So just depending on what it is you need, how soon or how far out you want to schedule it, we take it from there. And that is, the customizable courses are all on a sliding scale basis. So it's like pay what you can, but we are always willing to work with people who want this training to make sure that they're still getting their needs met as well. That's why we offer it on a sliding fee scale. And that is just for the customizable course. The ones that we post virtually to attend on a quarterly basis are all free and available to the public, but of course, donations are greatly appreciated for that as well. But yeah, did you want to add anything, Bethany?
Nope, I think you covered
Okay.
it.
Thank you.
Any other questions? I don't think I see hands raised, but feel free to come off mute if you have a question, or you can also put it in the chat.
Hi, Jody. It's Tom Olmstead. How are you?
I'm good. How are you?
Good. I just wanted to comment about Thrive for Change. I actually had some engagement with that organization and with Bethany in particular, going back a few years now. And it's remarkable the growth that I've seen in their organization and the impact that they have had. And clearly, it looks like they will continue to have going forward. So congratulations to Bethany and Ashley. It's nice to meet you, if not by video.
Thank you.
Thank you so much, Tom. It's good to see you on here, and thank you so much for those positive words. It's great to hear that the work is being seen.
Any other questions? And I believe Vanessa is still on, so if there's questions for Vanessa or Thrive, we can open it up.
I see a question in the chat,
Okay.
Jody, so I can take a look at it. Someone said, I found in the past that inpatient treatment beds in Cuyahoga County are often full. Is it
Okay.
possible that links you share help patients find programs and beds available? Seems that a lot of calls would need to be made to find a detox center. So I'll take that to start and then I can pass it off to Ashley. So the links in the EMS naloxone leave behind kit include a link to drughelp.care, which does attempt to try to display places that have openings. But also if someone reaches out to us in our linkages to care person, we have done a lot as a team to develop relationships with centers, whether they're in Cuyahoga County or there's some great centers that offer transportation that are in adjacent counties as well, that we can connect people to and typically get people in same day. Sometimes, depending on the person, they may have tried certain places and not all the options are what they maybe interested in or be available to them because of other conditions or their situation. But we really work hard to, sometimes you do need to make a couple of calls, but to get people in as quickly as we can. Ash, do you have anything to add to that?
No, I thought that was good.
Bethany, that brings up a good question. Is Thrive for Change on the Unite Us platform to accept referrals?
I don't believe we are, no.
Okay.
But I'd love to learn more about it and see how we can be included for sure.
Great. And do you get referrals through 211?
Yes, yeah, they
Okay.
Reach out to us to have us update our information and send people our way.
Great. Any other questions? There was a lot of food for thought here going forward. And I think our Opioid Consortium Advisory Council will have a lot to say of how we can look at this. I just recapping and reflecting on what we've heard today, that, all this work takes a lot of collaboration by partners, not only community-based programs like Thrive for Change and our EMS, it also is public health and hospitals. And so just really needing to focus on that collaboration in our community. It's going to take funding, as we heard from Vanessa, that she spends a lot of time writing proposals and seeking funding either through the state or through foundations. And so I know that is continually, we're always trying to chase where those dollars are coming from and available to support our programs. And then I think the third arm of what we heard is the policy change. And so I heard also Vanessa talk about how they've tried to make it easier through scope of practice. And Dr. Papp says, yes, in Ohio, that would be a hurdle. So just understanding that there is policy change that might have to happen in order to replicate some of this great work and to build off of maybe the work that Thrive for Change is already doing into a bridge project. So those were sort of the takeaways that I heard in the fluid conversation of today. I open it up for any other closing remarks from any folks or our Opioid Consortium members. Anything? Okay, so a couple of announcements that we wanted to share as well. Igniting Compassion, which was a documentary that the Center for Health Affairs released last year, has recently been recognized as a 2024 Gold Video Award winner, which is awesome. And so we just wanted to share that great news. There is in the agenda, there is a link to the news release on that and the link to Igniting Igniting Compassion. It's about a 32-minute documentary. And so it's not long, but it is a great opportunity to spur on conversation with community partners and have a dialogue. And we're happy to do sort of a discussion based on the documentary as well. And then September would be our next Opioid Consortium Forum, and we are proposing to have an in-person event for that. So you have a calendar hold, but I just wanted to bring that we might be changing that calendar hold so that we can offer an in-person event. And so there's a lot of great work happening in our community, and I know virtual is convenient, but because we need that collaboration, I think just having an opportunity to engage in person is important as well. So look for more details to come about the September Opioid Consortium event, and we hope to have it in person at the Center for Health Affairs. So with that, I believe we're almost finished unless there's any other comments from folks on the line. No, seeing none, hearing none. Well, then I would give you back 10 minutes in your day. And I appreciate both Thrive for Change and California Bridge. And Dr. Papp, thank you for making these connections with the California Bridge team, and Vanessa for pinch hitting. We do wish Dr. Hearn a speedy recovery, but we were so glad that you were able to join and share the story and share the remarkable work that you're doing. Thank you very much, everybody.